Welcome to the Heart of Innovation, 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group, thewaytomyheart.org, in partnership with Cardiovascular System Incorporated's patient advocacy campaign, Take a Stand Against Amputation. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kim McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hi, everyone, and welcome to the show. Dr. John Phillips was called in this morning into the cath lab for a potential surgical procedure to save a leg. It's what he does. He's on call this weekend. So let's just hope and pray that he saves this leg and the person can walk right out of the hospital with new, fresh blood flow to their legs, to their feet. He may pop in at some point during the show. So we'll just wait and see. But meantime, welcome. Today, we're going to be focusing on these circulation issues, speaking of circulation, that is impacting college football coach and former NFL star Deion Sanders, as we recognize that millions of people across the country may relate to his symptoms and want to learn more about it. What's most important is that we first call it by name, which was omitted from the discussion as well as the articles covering the story, the video that was online that was posted by Deion Sanders and his healthcare team. We'll get into a possible reason why the name of it might have been omitted. There's a little technicality in there that could explain that. But overall, in a broad perspective, we call this circulation issue that is impacting Deion and so many millions of others, peripheral artery disease, or PAD. Sometimes we also just call it PAD, with its advanced stage being critical limb ischemia, or CLI, sometimes also known as critical limb threatening ischemia, or CLTI, which is really what Deion is facing. PAD is characterized as plaque, such as blood clots or calcium, that is built up in the arteries, mainly in the legs, that restricts blood flow to the feet. Symptoms may include leg pain, leg cramps, neuropathy, with CLI or CLTI, the most advanced stage, presenting with pain at rest, non-healing wounds, which is really what Deion has, faced, and possibly even gangrene. Now, secondly, we find it important to share the standard treatment protocols for this circulation issue, which really were not evident in the discussion on the video that was presented on social media by Deion and his healthcare team. And we really feel that they're important for not only Deion to know, but also all of you, in order to reduce the risk of amputation because of it. We have with us today vascular surgeon Dr. James Antezana from Charlotte, North Carolina. And we also have vascular surgeon and secretary of the Society for Vascular Surgery, Dr. William Schutz, out of Plano, Texas. We might be joined by a few more vascular specialists, including Dr. John Phillips, but we will wait and see. Thank you so much, though. Meantime, Dr. Antezana, Dr. Schutz, for joining us. This is going to be a pretty powerful discussion.
I'm definitely looking forward to the next hour.
So
thank you, Kim. Likewise.
Yeah. So, and feel free. This is a discussion, so jump in anytime. If any listeners do want to call in as well with questions or insight, the number is 1-888-367-5329. Grab a pen, write it down, put it in your phone. 1-888-367-5329. Call with questions, concerns, stories, experience, insights, whatever you might have. This is dialogue, not me talking at any one of you. We're all here to learn. But I think we should start with the latest on Deion Sanders. And what I've heard so far is at least his first surgery he had yesterday was a success. The first one actually in this latest run of surgeries that he has. And they went in and they supposedly unblocked one of the arteries in his thigh. So that's really good. He has another blood clot in his other leg, which they're going to be scheduling another procedure, hopefully, to take care of that as well. But really starting this discussion overall, it really stems from his first video, which caused a stir with so many friends, colleagues, and even doctors who specialize in treating PAD, who were concerned that his vascular surgeon stating in the video that it just wasn't worth attempting to restore blood flow because the vessels would only close up. So amputation just was imminent, big risk factor for PAD. But then Deion released a second video saying amputation was never on the table. And in fact, he would undergo an attempt to remove the blockages in his legs Friday, which was yesterday, which I, mentioned was a success. And so, I really think that we should start out with Dr. Schutz and Dr. Antizana, sharing any initial concerns following the release of the video that you feel that are important to address before we get into the basics of PAD, CLI, and the standard protocols. Why don't we start with you, Dr. Schutz?
No, thank you, Kim. And I think this is a great opportunity to talk about communication. And without being in the room with the doctor and the patient, I can't tell you what was discussed or how it was presented, but communication is key. And unfortunately, when we get around a topic like this, there are issues where the providers are not very skilled in communicating the whole story correctly to the patient. And the patients and their families have a lot of anxiety, and that obviously distorts their reception of the message. So I think just what you described about the mixed messaging that we're hearing is a very common problem in what goes on in patients being evaluated and treated for PAD. So the communication has to be very clear and distinct and on both ends. And I would encourage any patient or family member that has any hesitation, any uncertainty about what's being discussed, to slow down the conversation and make sure that the person giving them that information is clear and they understand exactly what's being said, and they're not misunderstanding and thinking that it's hopeless to go on. When in fact we're able to save the majority of limbs unless their disease presents very, very late and very, very advanced, and there's so much tissue loss that it's really too late.
Yes, and Dr. Antizana, Dr. Schutz brings up a really good point in regards to communication, because after Deion's second video was released this past week, one of his fellow football buddies from another team was going out and broadcasting that, oh my gosh, he's got a blood clot in his groin. Oh my gosh, might as well cut off the leg versus his groin. And so that's not a really good message when it comes to PAD to be sharing. And it just speaks, to me that, yes, there was a communication issue. What do you think, Dr. Antizana?
Well, yeah, obviously, communication can get traversed and misinterpreted. People that don't understand the pathophysiology of peripheral artery disease will call a atherosclerotic plaque blockage a clot, which in reality it's totally different. So, if people are listening to this and they're like, oh, he got a clot, if you're a physician, you're going to think, well, maybe he had AFib and he threw a clot from somewhere, or a dissection or a ulcerated plaque that created a thrombus and a distal embolization. It's totally different than just a progression of vascular disease and atherosclerosis and a clot. Obviously, the understanding of peripheral artery disease is more at our grasp, because we can mitigate the effects of peripheral artery disease and we can prevent thrombosis of severe atherosclerotic plaque and save people's limbs. But it's important to understand that these things have to be detected early on in the disease stage, and then addressed appropriately so you can increase the flow to the lower extremity and save the person either from tissue loss or from rest pain or just severe claudication. So communication is key. I think physicians need to be able to explain to their patients in layman's terms what they're dealing with so they're not confused and they don't give misinformation to the rest of the community.
Yeah, I couldn't agree with you more, Dr. Antizana. And I would just like to add that early detection is really critical in conquering this disease. And PAD can be detected very simply without any expensive invasive testing in a physician's office. Many times it can be done just with a physical examination where pulses are checked and they're found not to be normal or missing. You can't feel them. So it can be done just with the physician placing his hands on the patient. And if a testing is required, again, it's the earliest test recommended is just a blood pressure measurement at the level of the ankle or on the toe. Painless, simple, inexpensive. And so early detection is really the key. And even if there's no symptoms associated, but if you have risk factors, say you have diabetes, you have hypertension, you have high cholesterol, you smoke or have a history of smoking, or you have a combination of that, it's very important to get screened. If you're screened and you're fine, then you can relax and continue with your life. But if you're screened and some is detected, then you're way ahead of the game in trying to beat this illness.
We'll return after these messages.
Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. We're talking about a disease more deadly than prostate cancer, breast cancer, and even colon cancer. It's critical limb ischemia or critical limb threatening ischemia, an advanced stage of peripheral artery disease, which is the circulation issue blanketing sports media as all eyes are on college football coach and former NFL star Deion Sanders, who has blood clots that are causing blockages in his leg arteries, putting him at risk for amputation. To really help the public understand this circulation issue, we are devoting the entire show to explaining the diagnostic and treatment options which align with society treatment standards. We have with us today vascular surgeon Dr. James Antizana and vascular surgeon and secretary of the Society for Vascular Surgery, Dr. William Schutz. Thank you to you both again for joining us. Let's start with with Dr. Schutz here, because the name of this circulation disorder, what we would call either peripheral artery disease or the advanced stage, which is critical limb ischemia, you touched on it in the first part of the show, both you and Dr. Antizana, that there are a lot of causes for arteries getting blocked up, and the society definition from the Society for Vascular Surgery of PAD, it's atherosclerosis of the leg arteries, versus, I think overall in the broader perspective, a lot of us end up looking at PAD as just a narrowing of the arteries that could be due to that atherosclerosis or calcium, as well as blood clots and maybe even other fibrous or scar tissue. What are your thoughts on that?
Yeah, there are many causes for impaired circulation and impaired circulation to the legs. The most common cause is atherosclerosis, which is, in the middle of a pandemic, despite all of the advances in treatment with the increasing incidence of diabetes and hypertension, that the number of patients being affected with atherosclerosis is rising dramatically. And atherosclerosis can affect any and every vascular bed in the body. And what we're talking about today is the circulation to the legs and that part. So the vast majority of patients with impaired circulation are going to have critical limb threatening ischemia or lesser severe type of PAD, resulting in a condition called claudication, and it's from atherosclerosis. And atherosclerosis, as I mentioned, can affect any and every vascular bed, including the brain, the heart, and other organs. And that's why, as you mentioned, that this disease is more deadly than many of the cancers that are present in our society. However, there are other causes, and it's important for the treating physician to understand those different causes, whether it's a clot called thrombosis, whether it's a dissection where there's an actual fracture of the lining of the artery that leads to impaired flow, whether it's an aneurysm, or whether it's a condition called arteritis. So those are just to name a few. Some of those other conditions that can be caused, the goal is obviously to restore blood flow, but then each of those illnesses and conditions that led to the impaired circulation will need a different type of treatment of the causative disease that led to that impaired circulation. So it can be quite complex, but when we talk in general terms, we're really talking about people that have hardening of the arteries, atherosclerosis, usually due to the conditions I mentioned, such as diabetes, hypertension, high blood pressure. There's a family history, there's exposure to tobacco, and then, high cholesterol.
Dr. Schutz is totally right. I mean, this is a complex disease, and there's many entities that contribute to the impairment of arterial blood flow. I think going back to his previous commentary about, screening these patients and communication, I think the first line of defense is identifying this pathology early on in its stage so we can have a thumb on it and control it, helping maximize risk factor modification, making sure that the patient understands their pathology and their condition and how they can prevent from progressing to CLI or tissue loss. And I think that's key. And education is important. We need to focus on primary care and enforcing protocols and education for them so they can help identify these conditions, especially when the patients have, all these red flags: diabetes, hypertension, history of smoking, family history of autoimmune conditions, arteritis, aneurysms, etc. All these things have to play. So the primary care physicians, the first responders to this type of disease, to be able to catch it early on and be able to detect it and be able to mitigate it, so we don't get to the point where we're dealing with critical limb ischemia.
Yeah, that's exactly right. I'm actually going to make a call out there that I think to lessen the confusion and with the prevalence of so many people having narrowed arteries in the legs for so many reasons, and without the early diagnosis, not even being discovered until they have CLI and they're a toe step away from amputation, that maybe we do formally expand the technical definition of PAD, because you're going to end up going to a vascular specialist anyway, and it's up to them to figure out why it is actually your vessels are narrowed. But I think that for the public, calling the whole umbrella, as we do, peripheral artery disease, and saying, hey, you have narrowed vessels, you need to go to a vascular specialist. The testing is still fairly the same, which we're going to get into the society protocols for testing for this circulation issue in the next segment. But I do think that we should end up, and I think from here, let's make that call for the broadening of the peripheral artery disease definition so that we can end up lessening the confusion and getting more people to the right diagnosis and treatment options.
Well said, Kim. And I would like to point out that for our listeners, that if you wait for symptoms, you already have advanced disease. And that's why screening is so important. And if you have any of these risk factors that have been mentioned, or if you have any concern that you have vascular disease, please get screened. The best moments I have in my clinic are when I get to tell patients they don't have vascular disease and go on about their life. So I'd much rather have folks come in, get checked, be reassured, so don't be concerned that you'll be, wasting your time or the doctor's time. Please get checked out if you have any of these risk factors at all.
Thank you for tuning in to The Heart of Innovation with Kim McNichols and Dr. John Phillips. We'll be turned to the conversation after these messages.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNichols and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. Dr. John Phillips is in surgery right now, helping to save a leg over at Ohio Health in Columbus, Ohio. We're sending the best to him and his team and the patient, that, they'll get up and walk right after this procedure is done to improve the circulation in their leg, which is ironic because that's what we're talking about, is circulation issues that could put your limb and your life at risk. We have Dr. William Schutz from Plano, Texas here. He's also the secretary for the Society for Vascular Surgery. And Dr. James Antozana from Charlotte, North Carolina, a beautiful new ambulatory surgical center there. attempting to save life and limb. And in fact, he helped one of our patients yesterday who has hope because of him. Excited about that. But before the break, we had talked about the importance of getting tested, and early testing is key, even if you're asymptomatic, if you have high risk factors, high blood pressure, high cholesterol, any family history of clotting, the importance of talking to your family about, hey, have you ever had these symptoms? Have you ever had a blood clot? Have you ever had calcium buildup or atherosclerosis? Do we have that anywhere in our family? Diabetes is another risk factor. Autoimmune conditions. Smoking, even if you've quit smoking 15, 20 years ago, you may still be at risk, and earlier is better, even when you're asymptomatic. So I'm curious, you're the secretary for the Society for Vascular Surgery, Dr. Schutz. What are the society guidelines for proper testing for PAD and CLI?
Well, thank you for asking, Kim. And it's a stepwise process. If the physician is concerned that there is a possibility of PAD, again, it starts with just an examination, looking at the patient's limb. There are characteristics that you can identify just with your eyes that will give you the heads up that there's some impaired circulation here. And then by feeling the pulses and assessing the blanching of the skin, you can get some pretty quick indications as to whether the circulation's impaired or not. Now, if you don't see those signs, but you're still concerned, the first test is always to get a blood pressure measurement just above the ankle and measure the circulation there and compare it to the blood pressure in the arm. And that's just called an ankle brachial index. It's been around for years. It's painless. It's done in the office. Very inexpensive. And in some patients, we also measure the circulation in the toes with a very, very tiny blood pressure cuff. And that's the first workup. Depending on what those findings are, then you can branch out into different areas of testing to determine how severe the blockage is and what that blockage pattern is. Everybody is unique in their pattern of blockages.
And it's important to note that with the ABI test, that ankle brachial index, it is possible that if your vessels are non-compressible, meaning that you have probably some rock hard calcium down there in your vessels, you might get that false normal. And it's really important at that point to, if you are symptomatic or if you do have these high risk factors, to ask your doctor to follow up with a leg artery ultrasound, correct?
Yes, great point. I don't know if people can understand that our beautiful little arteries that are so soft and flexible and can open and close with the heart cycle, but can become so severely affected with calcium that it turns the walls of those arteries into a bony structure that just is rigid and doesn't move. And so we can't compress it to measure the blood pressure. And we'll see that changes in the waveform that show that the blockage is impaired or the blood flow is impaired, but the blood pressure measurement will actually be normal or even super normal. So there are some clues there. But I've had other providers that aren't specialists in the world of vascular disease that misinterpret those normal findings, and the patient goes on reassured that they have normal flow, and an opportunity is missed and perhaps a limb is lost.
And Dr. Antizonas, in terms of those patients who are asymptomatic or have few symptoms, what is frontline treatment? Can we go into the society guidelines for the frontline treatment for PAD?
The guidelines are quite clear, and the first line of treatment for these individuals, depending on their grade of disease, if they don't have rest pain or wounds in their toes, is modifying all those risk factors that could be causing the atherosclerosis, putting them on an exercise regimen, walking 30 minutes to an hour a day, modifying their diet, smoking cessation, making sure their blood sugars are well controlled. Now we have a great great tool, which is called hemoglobin A1C, that we can monitor how well these diabetic patients are controlled, managing blood pressure. All these things are so important to modify the risk factors so we can mitigate the progression of disease. And yes, it is very important to interpret the studies appropriately and then send the patients to the right channel. And many times primary care doctors will misinterpret the symptomatology, and they'll think that because there's a normal ankle brachial index, and it could be just completely normal, it could be 0.9 or 1, and these individuals have underlying vascular disease. And the only way to detect that is with the keen eye, and that is sending the patient to the right specialist who understands peripheral artery disease and can carry on to the next level of diagnosis, which is a arterial duplex examination. And that gives us very, very, very important information. But it's important, again, to identify these issues early on, do the risk factor modification, and help mitigate the progression of vascular disease. And we're in an era now, and we're living it currently, of information. So patients have accessibility to great information, and anybody in the world, whether you're in Nepal up in the mountains, on Mount Everest, or you're in South America, or you're in a first world country, you have access to information that'll educate you and teach you how to identify these things and how to mitigate them, which is beautiful.
I hear that we have Dr. John Phillips on the line. Dr. Phillips, how did it go?
Just broke scrub. The patient's doing well. It was a nice procedure. We did a little hybrid approach with my vascular surgeon. The gentleman had occluded one of the vessels above his pelvis, and then kind of threw some clot down to the knee and lost pulses in his foot. So we pulled out some of the clot and put a couple stents in. He's got a palpable pulse now, which means he's not going to lose any piggies, and we live to fight another day. How are you guys?
Fantastic.
Good,
I'm
thank
sure
you.
Dr. Schutz and
thanks.
Dr.
Yeah, great
Antizana
job.
can really.
Yeah, great
Fantastic.
job. Nice save.
Yeah, every once in a while we get it right.
Well,
I think it's
very
more than
gratifying.
once in a while.
Yeah. And these are higher stress cases than normal, right? This is why we like early detection. We like to get to these patients early rather than when they come in more advanced, and what could have been treated in a very elective, safe manner now becomes an absolute door-busting emergency, right?
Exactly. So this gentleman had symptoms of buttock claudication, pain when he walked for several months, and then woke up this morning with acute onset kind of pain in his calf. He couldn't move his foot, and the foot turned white. And so he had a chronic occlusion of that artery in the pelvis, and so there was clot around it, and that clot had kind of broke free. So at any rate, we got him fixed up, and I'm gonna get back to him, and maybe I can call back in about 5-10 minutes here and join the rest of the show, if that's okay.
Sounds good. We look forward to it.
Thank you. Good luck.
Right here.
Hey, great job.
Okay. Thanks, guys.
Great job.
Take care.
And coming up right here on the Heart of Innovation, we will have a continuance of this discussion on treatment options for PAD and let you know when you might need an intervention or surgery, such as what John was just mentioning. So stay with us. Hi, everyone. Welcome back to the show. Before the break, Dr. John Phillips chimed in live from the operating room at Ohio Health in Columbus, Ohio, where he had just saved the leg of one of his patients who had a circulation issue, which it seemed had an acute onset of symptoms, which made his leg cold and required immediate surgery to remove the clot. And during the break, Dr. Schutz and Dr. Antizana, you had some really good points there. Do you want to chime in with your thoughts?
This was a very interesting case that Dr. Phillips presented. And this is a classic example of an acute limb ischemia. And it's very important to that when you have a patient with underlying peripheral artery disease that you mentioned that there is a possibility that all of a sudden they can have a very painful lower extremity and they can suffer weakness and ongoing pain and even profound numbness at some point if it is a thrombosis, and that's a surgical emergency and it needs to be seen immediately by the treating physician. We treat these individuals in that acute phase with a combination of things such as clot busters and sucking out clot and removing them, and then addressing the blockage where they started. But the etiology could be complex, and it has to be multidisciplinary approach to treating them, having cardiology on board, making sure that these individuals have the appropriate care to identify why they clotted, because sometimes it may not just be a fractured plaque. It may be that the patient went in and out of atrial fibrillation and through a clot, or they stopped their anticoagulation for AFib and they clotted up. One of the protocols for my practice on my patients with PAD and the patients who are at high risk is the utilization of Xarelto, which is a direct oral anticoagulant, and at a dose of 2.5 milligrams twice a day, it helps mitigate the effects of thrombin that are circulating in these individuals and that make them hypercoagulable, helping them prevent these catastrophic conditions. What do you think, Dr. Schutz?
Oh, I totally agree. And I'm a big fan of adding Xarelto to the antiplatelet therapy to minimize thrombotic events in our patients with peripheral vascular disease. It's nice to see the evolution across the country of it as it gains adoption and is moving more and more out into general practice and general usage. And it's just another tool in the toolkit that we have to take care of patients. And so when we talk about PAD, it doesn't mean you're going to have surgery. It doesn't mean you're going to have a stent. We have all these tools now to try to prevent or delay needing some type of procedure done. And again, you just have to be, under the care of a good vascular specialist and embrace the idea that you can co-manage your disease by adhering to the recommendations and trying to avoid that trip to the cath lab, avoid that trip to the operating room.
But it's interesting that in a situation such as this patient, they were very lucky that they didn't fall victim to the referral lottery or the ER lottery, as we call it, the amputation lottery, because at another facility, that patient may not have been as lucky to find someone who is an interventional limb salvage specialist, whether a vascular surgeon, interventional cardiologist, or interventional radiologist, someone who could go in and has the skills to get behind the knee or below the knee into those small vessels, into the calf and into the foot, to be able to remove some of that clot or whatever is causing that blockage in the critical limb ischemia or the critical limb threatening ischemia. And I've had patients call me from the emergency room saying, I was just told by the doctor amputation is the only option. And I say to them, society protocols, and including from the American Heart Association, the protocols state that an attempt should be made to restore inline flow prior to any amputation. Now, the exception to the rule is life on the line versus limb. And so I'll let you both go into a little bit on that as well, because it's really important for patients to know the protocols prior to amputation.
No, I totally agree. And it's never comforting for a patient to hear that their only option is amputation. And I would encourage every patient or family member of a patient that's had that recommendation, even in the rare instances when it is the correct one, to get a second opinion.
Unfortunately, the second opinion may be a problem if you're out in a community where there is not a vascular surgery support. Then you're at the mercy of the physicians that are there, and it's sad because not all of us have the same training, not all of us have the same approach. Experience is very important in this entity. And if you don't have and you lack the experience, then your patient's going to suffer.
That's a great point, Dr. Andizano. And underprivileged communities, underrepresented communities are most at risk. And that includes the rural areas where, as you mentioned, there's a limit on the number of providers or availability of providers. And while it's challenging and there may be barriers to transportation, if you're out in a rural underserved area, you may have to just make the trip to get into a suburban or urban area to get to that highly skilled provider.
Yeah, and that's what we're really struggling with actually around the world is I think that the Society for Vascular Surgeries and the AHA's guidelines they can't go far enough because of the still gaps in education of newer, more advanced limb salvage techniques. And so while an angiogram can be performed, there are still a lot of doctors that are not trained or don't think it's effective to take wires and balloons and plaque removal devices below the knee. So they're following society guidelines by saying, hey, we went in, we attempted to restore flow, but they don't say that they didn't go all the way down to the point of where that flow is truly obstructed down near the ankle, because they just don't know how, or might be using a certain subset of data that may say, hey, it's not effective.
Yeah, good point. And I'm sure Dr. Anazon's had the same experience as I have, working in, a southern state with a lot of rural areas around. Our phone is always available to do a phone consultation. It's very easy to see imaging now, with the use of our phones that can transmit imaging, including arteriograms and CT scans. So there are ways to get consultations outside of your rural community with a specialist in a highly skilled center.
We're going to have more on this discussion. So much to say, so stay with us. Welcome back to the show. Dr. John Phillips is still in surgery on one of his patients, saving a leg today on this Saturday, an emergency patient. But we're talking about, it's so ironic because we are talking about circulation issues, the exact circulation issue that is infecting Deion Sanders, affecting millions of Americans. And I'm talking with vascular surgeon Dr. William Schutz and also Dr. James Antizana. We only have a few minutes left in this segment. So, really what we're trying to do here is we want to empower the patients, like the movement for, breast cancer and the Susan G. Komen Foundation, where patients were going into their doctor and saying, hey, I have these risk factors, I have these symptoms, I need this treatment, or I don't need this treatment, or I know there's another treatment available aside from amputation. Let's talk about it. I need that referral. And hopefully we can do the same and inspire these doctors to learn the new advanced limb salvage techniques and adopt them and practice them daily, right?
Absolutely. And I think as a patient, you should feel empowered to question your provider on their commitment to treating peripheral arterial disease. As Dr. Anzana mentioned during the break, training, education. What is their training and education? Is this something that they have a rich background in? And have them explain how their background demonstrates that they have a rich background and education in peripheral vascular disease, and then what's their commitment to it? How much is treating peripheral arterial disease a part of their practice? Is that something they do some of the time, but most of the time they're off doing something else? Or is this something that they're totally committed to, and it really takes up a significant amount, on 20, 30, 40%, or even 100% of their practice? And again, also ask them what they think of the guidelines, the SVS guidelines. If that person doesn't know about the SVS guidelines, it might be time to take a step back and consider, is this the right person for you, especially if you're being advised to have a complex intervention.
I think that is so important to say, hey, what are the guidelines for treatment? For example, we have a patient in Pennsylvania that she has been told by 4 different surgeons she needs an aortobifemoral bypass. They've never actually gone in with a wire to see if they can traverse the blockage with a wire. And she's a 70-year-old woman with a heart condition, and society guidelines actually say that endovascular is preferred as frontline treatment. And if that fails, then you can go to a grander procedure, open procedure. But people just don't know. So that's really important to ask. What about you, Dr. James Antizana? What are some of the questions that you think that patients should be asking to ensure that they're not only getting the right treatment for them, but make sure they meet guidelines, but also that they're getting the right doctor with advanced skills?
Well, I totally agree with Dr. Schutz. He hit it right on the nail. I think it's very important to understand the experience your physician has in dealing with this condition. Like any other condition, if the physician has the experience and has the volume of patients that he's been treating, he becomes a master at it. He's not a jack of all trades. And that's very important. Experience in your position and dealing and managing this entity is very, very important to understand. And again, the fact that we have access to information, access to reviews online, access to the quality of care of a lot of our colleagues out there, gives us that power to be able to decide which physician is the right fit for us.
Right. And it has nothing to do with title and publications and how many times they've been on a podium somewhere. It's really their tangible, actionable skill set that should be paramount when you're selecting a doctor. And I even would go to the extent to say, I want to know your technical skill set. I want to know the tools and techniques that you are using for limb salvage, whether or not they're medically appropriate for me and you need to use them on me. But I want to know that you literally have the most advanced armamentarium possible. So why don't we jump in with Marcia? Marcia, what is your question?
Well, PAD's really been on my mind because I'm now dreaming about it. So I'm wondering, how do you really know if an intervention is your best bet, especially if you've already had a few? I was thinking like the different specialists that work on PAD. You have vascular surgeons. Well, what they do is surgery. So they're going to want to do surgery. Like an interventional cardiologist might want to do stents. How do you know it's really necessary versus that's what they do? So that's what they're going to recommend.
That's a great question, and probably the most important question related to this topic. Yeah. Dr. Arizona, would you like to take a first stab at that? I can do
Dr.
a follow-up.
Schutz, no, Dr. Schutz, you first. Go ahead.
Okay. Well, let me just clarify.
It's a tough question. It's a loaded question.
Yeah. Let me just clarify one misconception about vascular surgery. Although vascular surgery is part of our nomenclature, we're vascular surgeons. We don't do just surgery. We've been in the endovascular space since the 1990s. And have helped move the technology forward. So if you're seeing a vascular surgeon, you're most likely going to be somebody that has the entire toolbox to do procedures in addition to the medical treatment. So you'll have somebody that can do stenting, can do balloon, can use the IVUS that was mentioned, can do percutaneous thrombectomy, but also has the ability to actually pull out plaque. That's called endarterectomy, or to do a bypass. And there actually are, every patient is unique, has a different, body medical history with all the other illnesses and risk factors they have. They have different goals, and then their pattern of disease is different. So we try to tailor all of those tools to fit the patient. If you're seeing somebody that doesn't have all those tools, then yes, you're right. They may only want to offer you the tools they have, but that doesn't have to be the entire discussion. All the other options should be discussed as well. And if you don't feel that you're getting that complete discussion, then again, I would ask, say, hey, let me just talk to another physician, and we'll work together as a team on trying to get the best care. There's no downside to having team-based care for this disease. And I collaborate greatly with my radiology friends, my cardiology friends, when we co-manage these patients, and we just tailor the care to the patient and what their needs are. Now, when you get back to, is this procedure truly needed? That's important. And I think when it gets down to CLTI, where the limb is threatened, there's a non-healing ulcer on the toe. You have pain in your foot that wakes you up at night, and you can't get any rest because you have to get up and let your foot hang down. You actually have gangrenous changes in the skin starting, or even frank gangrene. Well, then it's pretty clear something needs to be done. Now, again, what needs to be done? I get back to my recommendation that you just have a comprehensive evaluation and recommendation of all the options that are available so you can pick the right one. What do you think, Dr. Henderson?
No, I totally agree. I totally agree. Us vascular surgeons are a unique breed in the medical field. We are not just looking at images in 2 dimensions, but we understand the third dimension, which is the open dimension, where bypasses and endarterectomies and that type of work is in our repertoire of procedures that we can offer our patients. I think it's very important to put a balance based on the patient's symptoms and comorbidities to make the right decision for the patients. And going the route of a minimally invasive approach has been the trend, and the trend to minimize scarring and minimize surgical time and exposure to anesthetics to our patients that suppress and can cause complications such as myocardial infarction on the table, or a respiratory condition, is mitigated by these endovascular approaches. But not every patient is a candidate for an endovascular approach. And in our mentality and our ideology early on, we believed that doing a bypass on a younger patient was the appropriate thing to do. But now we're realizing that even the endovascular approach for the younger patient is beneficial, and can be long lasting if we can mitigate the risk factors in these patients. So
and I think that's really important too.
It is, and it's a multidisciplinary approach, working with cardiology, endocrinology, internal medicine, podiatry, to maximize the results of our patients that we intervene on.
Yeah, I totally agree, and I think there's 2 areas where if a patient is offered an intervention or procedure, that they should really be very careful about accepting that recommendation. And those two situations are when you're identified with PAD, but you have absolutely no symptoms. You can walk as far as you need to go. You're not having any of the CLTI symptoms, but the recommendation is, well, you have blockage, it needs to be treated. But if you're not having any symptoms, the treatment is not going to change the course of the disease. The disease is not cured by doing a procedure. It's addressed by doing the risk factors modification, taking the medications that are needed, getting on a walking program. In fact, we now have good evidence that people that are treated early for their minimally symptomatic disease are more likely to end up having an amputation. And that's evidence that's come out the last 2 years from large national data sets from Medicare.
That's scary.
It's very scary. It's the exact opposite of what the mantra of medicine is, which is first, do no harm. So those are the situations where you really can walk, do all your things, but you may have some blockage, or you have absolutely no symptoms with blockage. You're more at risk to losing your leg if you have a procedure done in those situations at that time.
You have to really, and this is one of the things that sets us apart when we're, as an organization, and how we work with patients and how we educate them, is we also want to make sure that not every doctor is going to treat in the same way. You can end up with a doctor who has a high volume of cases and they have 2 different cath labs running at once, and they barely go in to touch the patient, and they have a technologist that's kind of helping them in one room while they're trying to run back and forth between the 2, and they try and rush through the patient, get them in and out in less than an hour and a half. Like, those are not the ones that you want when they're bragging about they have 18 to 20 patients they go through a day, and boom, 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 I'll have you in and out. No, because they're likely using higher trauma techniques, right? Usually 4 to 5 patients in a day is really the limit for a true limb salvage specialist, because sometimes they may need to spend 3 hours on a patient. But in terms of the techniques used, one of the things we drive home is, one, the use of the intravascular ultrasound, or IVUS, number one, because I think that, and I've actually seen things missed because it's not used, including a dissection where something's gone wrong and the person ended up with amputation because they said, looks good in the 2D image, we're done. And there was a dissection in there and it was flow limiting. And ultimately, the person a week later ended up with an acute situation and amputation. But we also encourage the patients to say, hey, no 0 to hero, doctor. I do not need you to go from 100% blockage clear down to a 20%. Just kiss it with the balloon. low and slow, doctor. Just ease that balloon up. We're not, don't go in there and just put all your might into it. So some of those things have really helped prevent an overuse of stenting as well in a lot of our patients. So really important questions to ask, and really important to know that not all doctors are created equal. And simply because they have the title of vascular specialist and they perform interventions, it doesn't mean they're using those advanced lower trauma techniques that can reduce the revolving door of treatments, right?
Absolutely. I totally agree. And
Yeah.
you have to be minimally invasive. That's why the technique is called minimally invasive intervention, right? And if you can minimize what you do, and if you can prevent stenting the patient, then you're going to be better off. But sometimes you really do have to stent, and that is a call you make based on your experience, what you're looking at, the images, and obviously, the symptomatology of the patient. And Dr. Schutz is totally right. I mean, we've got patients who have 100% SFA blockages bilaterally. They're active, they're walking, they don't have any claudication, and there's no need to operate on them. If they can walk and they have no discomfort and their lifestyle's not affected, you don't need to touch them. And I've got patients with multi-level disease that's significant, but they don't have rest pain, and they're high risk for doing anything. So we just manage them medically and we optimize them. And the most important thing in optimizing a patient with PAD is walk, walk, walk. It's increasing those collateral beds, so you have more blood flow distally. You may not run a marathon, but you can walk through the store.
And that's what's interesting is the first thing that Douglas, our PAD warrior chief over there, said to me when he saw the video, and he was disturbed with the fact that the doctors didn't talk about the collateral vessels, that's the number one thing that we talk about. If you go in our groups, everyone is talking about building their collateral vessels, and they love to understand how they can build those natural bypasses around the blockages. I have a 94-year-old woman we work with, and she has nearly 100% blockages in her external iliacs bilaterally, and she is doing great. She was first diagnosed at age 50, never had a procedure, walks, optimum, medical therapy over the years, and she's still working in her law office. It's
Wow.
absolutely amazing. But when you look at a CT angiogram at her legs, the tree roots are everywhere.
I think Dr. Schutz and I have seen that multiple
Yeah.
times in our patients.
The body is an amazing thing, and it can reroute blood flow around complete blockages in just a miraculous manner.
Yep, absolutely. Life finds itself. There's ways to survive. It's unbelievable.
And Douglas, you want to jump in with your question?
All right, welcome. Been a great conversation. I want to kind of step outside the box just a little bit here. We're talking second, third, maybe fourth level with our patients, but how do we get that to that first level where the primary doctor checks her feet? As an LCDC, which is a licensed chemical dependency counselor, I had to have training every 2 years to stay up with the technology. As our primary physicians, I understand that if they want to get education, they do it on their own. It's not a requirement. So how as a group can we get our primary doctors on the first, second, or third visit when I walk in and say, I can't feel my legs or I have trouble walking, and he says, pull off your shoe, take off your sock, let me check your feet. Because usually by then, like I think Dr. Schultz said it, by the time I got to my vascular surgeon, I was already blocked. It was too late. Are y'all following me?
Oh
Yeah,
yeah,
and they
absolutely.
Yeah.
continuing medical education credits that are required on an annual basis in order to do. But I think the issue is that the physician can choose an area of interest, correct? Like when you go to those conferences, and the conferences, physician conferences say, hey, you go to these certain sessions and you get CME credits. They can choose which ones they go to.
Yeah, that's correct. And I think what the issue that Douglas has brought up is related to the way medicine is being practiced now in the front lines. And our frontline physicians have to hit certain metrics for related to how CMS and the insurers are going to pay them. And those metrics are not related to whether they've detected PAD at an early time or not. They want to know about, if they're diabetic, when was the last time they measured the hemoglobin A1C? If they're hypertensive, what are their systolic blood pressures, right? Have they performed the appropriate cancer screening? Are their vaccinations up to date? So they're focusing on that. That's top down. That's been pushed out to primary care. This is important. Screening for PAD has not been, and it needs to be. And so I think what you brought up, Doug, is the way that medicine has been morphed based on top down, I guess, visions of what's important. We have an epidemic of PAD in this country, and as Kim mentioned, with a mortality rate that exceeds many cancers. So we need to advocate to get PAD screening to be one of those metrics that our frontline providers, have to report on, and then they'll screen. They'll actually have the shoes and socks come off and check the pulses, or do a simple screening test. And the screening test can be done in any office anywhere. The equipment to do screening with the blood pressure tests is very inexpensive now.
Dr. Schultz, I just wanted to add, I was actually diagnosed by my primary care. And I was so pleased. I didn't know anything about it, but she did.
Good. You have a great doctor.
Yeah, except for the rule.
Mm-hmm.
And Douglas, do you want to facilitate the next set of questions? I think
let me go back up. Cameron had a question. Are you there, Cameron?
Yeah, I'm here. Can you guys see me?
Hey,
Yes.
bud.
Yep.
What's your
Hey,
question?
I'll try to keep it quick because sometimes my questions don't apply to everybody. But I was curious what the actual guidelines were, the official guidelines for patients on the younger side. Because I've seen several doctors. I've actually seen Dr. Antizana. Nice to see you again. And they had diverse and strong opinions on what's appropriate and what's not appropriate. And then from my own reading, because I've probably read, 50 to 100 different papers in the last year. From my reading, a lot of them seem to indicate, regardless if it's bypass surgery or endovascular, if the patient's young, the rate of failure is very high, from what I could see. So I was curious what the official guidelines are for that, on when to intervene and which type of intervention is appropriate, because I've heard different things.
Well, I think the standard of care for younger folks is bypass surgery if you have like an SFA occlusion, because it will last longer, you'll do better in surgery, etc. But it also depends on the entity, the pathophysiology that you're experiencing. What type of disease do you have? Is it arteritis? Could you benefit from steroids and an angioplasty, versus having to have a bypass? Or is it adventitial cystic disease or popliteal entrapment? It just depends. Every pathology is different. Now, when you're older, above the 5th, 6th decade, and you have atherosclerosis, then we're talking about a different approach, an endovascular approach versus a bypass surgery. And you have to put on the balance whether the patient has, the comorbidities that are controlled enough to sustain a 4-hour surgery or a 2.5-hour surgery for a bypass, etc. What do you think, Dr. Schutz?
No, I totally agree. Age is something that we put in the algorithm in trying to tailor the revascularization procedure to the patient. And in younger patients, I totally agree with Dr. Anizano. The chance of needing the durability of a bypass is going to be much better than a stent. Or just an angioplasty. So,
although what are the options? What are the options when that fails? Because that's the issue that we have been dealing with. Is once that bypass fails, then people are saying,
Yeah.
well, sorry, it failed,
Well, I
amputation.
only have so much vein available to harvest, right?
Right. Yeah. Well,
It'll run
that's
out
my next
eventually.
point is yeah, if you have a good quality vein, that's what should be used for your first bypass. And the good news is when the vein bypass fails, it doesn't worsen the disease compared to using, say, an artificial graft. So when the artificial grafts go down, typically you're worse off and you'll need either a more extensive bypass. But just when the bypass goes down, we can still rescue most of those patients. It's more challenging, but if you're in the hands of a dedicated provider, vascular specialist, we can salvage most everybody who's had a failed bypass.
So the question is, as a patient, then when we're told that first time a bypass, if we don't know nothing at all about it, we just have to assume that's what's needed. So what kind of questions can we add as patients to our doctors about, wait a minute, hold on, time out, can we do this? Kim says this a lot too. Are you able to go through the foot now and do this? Or is bypass my only option?
I don't think there's ever only one option. There's always several options, and you can. There's no reason you can't put your doctor on the spot and say, all right, what's option number 2, and why isn't that as good as number 1? What's option number 3, and why isn't that not as good? And then at the end of the day, if you're going to go with option 1, you need to say, okay, well, how long do these typically last, and how often do you have to go back in and perhaps redo them while they're still working? Those are really 2 important questions.
And
I totally agree. And the other question I would ask is, how many have you done and what's your success rate? Because again, we're not all equal. And you might have a physician that does 1 bypass a month or a couple of bypasses a year. And, he may have 100% success rate. But if he did 100 of them, in a year, what would be his success rate? There is a lot of technicality behind doing a bypass. And if you're a great technician, you can get a great bypass with great outflow. And it can last you for the rest of your life if you follow the guidelines and you do the risk factor modification. But these bypasses generally, if you don't follow the guidelines and you continue smoking, they won't last you, but maybe a year. Ideally, they should last you over 2 years, and close surveillance of your graft or any intervention that's done by your vascular surgeon is very, very important. That's why I tell my patients, I'm like, when you guys come to me, you've inherited me if you accept me as your vascular surgeon until you die or I die. And the reason I tell them that's because vascular disease is ongoing. It's not like general surgery. You take a gallbladder out, the gallbladder's not going to regrow. Vascular disease, unfortunately, is a progressive disease. Yes, we can mitigate it and slow it down, and many times really control it well and get longevity in our patients. But the habit of smoking, of falling into the poor habits of eating, will also get the best of us. And at the end, it will cause our disease to come back. So talking to your physician about their success rate, how many procedures do they do a year, what are their complication rates, are very important to understand whose hands you're going into. That way you don't play the Russian roulette.
Yeah. You make great points, Dr. Andizana. And I wanted to piggyback your comment about surveillance and coming back to see you. And I think for our patient advocates present, that's another discriminator you can use when you're interviewing your physician before he or she's done anything to you. You can ask them, well, how often will I need to come back to have this checked? And if the answer is, well, no, you're good, then you're not in the right office. You need to have somebody committed like Dr. Antizana that says, you will be seeing me from now on. And I will be checking you regularly.
Sometimes you have patients that are, going in every 6 weeks, right? But for the most part, for our more acute patients, we try and tell them to get in every 3 months, and we're closely watching them on our regimented walking program. We have a text-based walking program. But thirdly is for everyone else, I always say, just as you go and get your teeth checked, you should go and get a checkup at least twice a year with your vascular specialist. And even if it's just one appointment, that is double checking your bloods and having a conversation about whether you're on maximum medical therapy or if any changes need to be made. I think that that's really important when it comes to not only PAD, but CAD. And even more importantly, at that point, once you do have PAD, that you do need that second appointment during the year to also discuss, well, do I need a referral to a heart specialist? Do I need special scans? Should I get a stress test or an echocardiogram every couple of years? Because as Kim was asking a question over here in the sidelines, if a person has PAD, does it mean that they will also have problems possibly with their heart or their carotid arteries?
Yeah, absolutely. Yeah, absolutely.
Yes.
It's a total body disease. It's a total body disease, and every blood vessel needs to be checked once you've been diagnosed with PAD. Doesn't mean you need a test, but at least the doctor should be listening to your neck. They should be checking your pulses everywhere, right? Considering and if you meet the guideline criteria, you might need to be screened for an aneurysm.
Correct.
I always, that's really important too.
Or family history. Yeah.
I
know it's important
to chat with the doctor. CHAT, that's an acronym. So every appointment you should always chat, check my carotids, check my heart, check my abdomen for a bruit, right? It's spelled brute, but check for that turbulent flow inside my abdomen, possible aneurysm present, right? And check my toes. Take off my sock stock. Let's feel those leg pulses and foot pulses to make sure that I have good blood pressure and flow going clear to my toes.
Is there a difference between like a vein bypass and like a where they put a graft in you, and how that affects your body?
Yes, that's what they're saying, the artificial versus the real vein, right?
Yes.
Yeah, absolutely. There's a preference for using your own vein, if you have good quality vein. But a lot of times we can elect doing a bypass above the knee with a synthetic graft like a PTFE, and the longevity of that and a vein is very similar. But ideally, it would be best to have your own native tissue in there, because then you decrease and minimize the risk of infection. Grafts have a tendency to get infected, and if you're a poorly controlled diabetic, you're having a groin incision or a lateral knee incision, those incisions can fall apart and the graft can get infected. And even if it heals over, you still run the risk that you might have seeded that graft with a bacteria that just lingers on for a while until your immune system drops. And then, all of a sudden you develop an abscess and you're septic, or and then your graft has to come out, and then years have passed and your disease has gotten worse. So it's all put on a balance, and it's what availability we have for a conduit for a bypass that's important.
I would just say sometimes when patients say, "Well, doctor, what would you do if it were you or your mom or dad?" And I'd say, "Well, I would like you to use my vein for the bypass, please."
Yes. I just want to reiterate just an important point, and then we'll get to you, Shorty. It's just in terms of, we still always, when we look at those guidelines, I always still err on the side of at least try an angiogram before any sort of bypass, doc, because until you go in, I've seen so many cases personally with my own eyes. We're going in and actually with that intravascular ultrasound and seeing that morphology of the plaque and taking a wire and just seeing if they can poke through. I've seen people think that an aortobifemoral bypass is needed multiple times, and it's like, whoa, I went right through it. No big deal. A little bit of thrombolysis, maybe a little thrombectomy, and this patient is good with maximum medical therapy coming out of it and didn't have, huge cuts down their abdomen and into their legs. So I always think it's worth doing not just a CT angiogram, but getting someone's hands in there with a wire and an intravascular ultrasound can really make a difference. At least to see, hey, if it closes up in the next 6 weeks, then go straight to the bypass, right? But make sure you're on maximum medical therapy first and you have those lifestyle modifications in order.
it is a discussion that us vascular surgeons and our interventional colleagues always talk about, right? Interventional colleagues, they get these patients, and the only thing they can do is offer an endovascular approach versus a vascular surgeon. We can offer both. And we put things on a balance based on our experience, based on our schooling and our technical skills and abilities. Yes and no to that response, Kim. Sometimes, yes, you can go through there and repair something, and you know it's going to last because we understand as clinicians and as interventionalists that outflow is very important. So if that patient's got a 3-vessel runoff and you've got a short segment SFA occlusion, yeah, most likely you go through there, you clean it up, you stent it, with the appropriate stent, and you're going to have good longevity. But if you go in there and angiogram and you have a popliteal lesion and you're going through that popliteal lesion and burning the bridges that your vascular surgeon could have used to do a bypass, then you put the patient in dire straits. And then that's when we start getting into the situation where, we could lose limb.
I think you just brought up a key point. I just want to reiterate, this is really even another one that's so important is anytime someone's going in there, even for an angiogram, you always, I think, have to remind the doctor saying, hey, you know what? I don't want to end up limiting my options in the future. So can you keep in mind a potential landing zone in case a bypass is ultimately needed?
Absolutely.
Really
Yes.
important.
Yeah. And to Dr. Anzana's point, there's a term called full metal jacket.
Yeah, God, I've seen
Yeah.
those.
Now, full metal jacket for our listeners means, the stent starts all the way in the groin and goes all the way down below the knee. And the main issue with that is when that fails and the patient ultimately needs a bypass rescue, your distal target, which used to be the artery just above the knee, which has the best long-term results, has now been moved to below the knee, which has acceptable but much inferior results to compare to if that target was above the knee. So that bridge burned, to your point, Kim.
And
Absolutely, but at the same time, you may have a full metal jacket on a patient who's got a very poor ejection fraction, who's not a good candidate for surgery, who's in extreme age, in the 80s, and that's the only thing you have to save the limb. And I have patients that have full metal jackets that didn't start with a full metal jacket, but that they're in their 8th decade of life, closer to the 9th decade, or even their 9th decade. And I've been monitoring and maintaining those vessels open, relieving them from their rest pain, and sustaining the limb in that manner. But if you see a young patient, in their 6th decade of life, 7th decade of life with a full metal jacket, you always wonder, what was the disease like? Why does he have a full metal jacket? Yeah. So it's interesting.
Can you explain, Dr. Schultz, how that moves? You were talking about it goes from above the knee to below the knee. I didn't understand what you meant.
He was talking about the bypass.
If we do for the bypass procedures, the most durable results are when we're able to hook the bottom end of the bypass into the artery above the knee, compared to when you have to go further down below the knee to hook your bypass in.
So if it's all filled with stents, you can't do that? Is that what you meant?
Well, when the stents fail, they're blocked up, and no, we can't. We have to go to a vessel that hasn't been stented that's open.
It depends on where the stent is, Marcia. Like you're not stented from groin to knee. You still have a good landing zone there.
Oh.
Yeah.
So, and we try to preserve the good landing zones just in case we need to do a bypass surgery. Right. Because if the stents that are long in the SFA fail, then the next step is to do a bypass procedure, which is going to last a lot longer.
Right. And I agree with Dr. Anzana that there are patients that are not candidates for bypass, and they are the ones that, we do everything endovascular we can, stenting and surveillance and repeat procedures, and that's a different cohort than what I was referring to earlier.
Hey, good evening to everyone. There's a very good topic, and y'all covering a lot of great things. That's why I like listening and learning. But however, my question is very simple. Is there any real cure to a person with PAD that has clots or blockage? For myself, I have bad blockage. And my good leg now, my left leg has been amputated above, and I'm having major problems with the right leg. Sometimes if I do too much, my foot swell up. I'm not able to walk with my new prosthetic leg as of yet. I guess I go back in another week and hopefully come home with the leg. So that's a question I have. One of the questions.
Unfortunately, Shorty, yeah, there's no cure. All we can do is manage it. Just like a disease like diabetes. We can't cure diabetes yet, but we manage it with multiple medications and lifestyle, diet, everything. And you just try to manage it and minimize it from getting worse. With this disease, we throw everything at it that we can. And so somebody in your condition with very advanced disease is supposed to be on 2 antiplatelet medications, aspirin, and then another medication like Plavix or Brilinta. That you should also be on maximal cholesterol medication, a statin, if you can tolerate it at the highest dose, because that works better than the lower doses in trying to keep this disease in check. And then, as Dr. Enizana mentioned earlier, if someone in your situation was in my practice, I would be adding in this medication called Xarelto. To again, as we know, it adds one more little layer to your body to protect it from forming clots on those plaques. And then, of course, all the other things that need to be just optimized. If you're a diabetic, your hemoglobin A1C needs to be 6.5 or less. You know, your LDL target needs to be 70. Your systolic blood pressure needs to be 130 or less. All those things are just critical to trying to contain this horrible disease.
If you are advancing, and we see this all the time, that so many of our patients are advancing, and then I ask them, well, are they taking a second look at medical therapy and making sure they're on maximum medical therapy, or even just the right medical therapy? And so it's really important for you to sit down with your doctor and not just go through this revolving door of treatments, but stop for a moment. Say, hey, doc, let's stop. Let's really address what's going on here. Let's look at my lifestyle modifications. Let's do some extra blood work. Let's make sure I'm on the not just maximum medical therapy, but the right maximum medical therapy. And it's really up to you sometimes to stop them and say, hey, doc, let's just take a step back for a moment and make sure we're doing the right, everything that we can do outside the cath lab. Yeah. Because you don't want to go back in and then have to go back in again and again and again.
Yeah. And if the disease continues to progress despite everything maximally being done, I've had a few patients that we've watched their disease progress. We're doing everything we can. They're doing everything they can. What I've done is used a lipid specialist, and there's different specialties out there. Usually they're from a cardiology background, but they're lipid specialists, and they have access to medications that I can't prescribe and that I don't know how to prescribe, but they can take your lipid control to a whole different level, better than your primary care can. So you can ask for a referral to a lipid specialist. They'll dig deeper into your lipid panel and take it to the next level of care, understanding exactly what your profile is, and get you on the most intense treatment available.
I think that's where I'm at. My doctor just recommended the PCSK9 inhibitor and fighting with insurance to get it paid for, because the atorvastatin doesn't seem to be doing anything.
Yeah, we've got these incredible miracle drugs that are doing like wonderful deeds with lowering lipids, but at the same time there are supplements that do help and can mitigate the cholesterol levels and even blood sugar. And one of my favorite supplements is cinnamon. Cinnamon has shown to have anti-inflammatory effects on our receptors, and it makes them more receptible to insulin, decreasing the insulin resistance and helping us control blood sugar better. Unfortunately, you can't take cinnamon ongoing every day. You have to give yourself a break. Usually after 4 weeks, you rest for 2 weeks, and then you can continue again and take the Ceylon cinnamon, which has the best concentration of cinnamon that's beneficial for you and the least concentration of coumarin, which affects your vitamin K coagulation factors. And then the other supplement that I've known about for many years, and it's been around since the beginning of mankind, And just recently in the past 2 years, I've become a greater proponent, thanks to Kim McNicholas, is extra virgin olive oil. People along the Mediterranean, the Mediterranean diet is a very, very tasty diet, but the whole premise of the Mediterranean diet is the olives and the olive oil, and it's not the tzatziki sauce and the lamb chops. The people along the Mediterranean fall in the same bad habits we Americans, have, and that is smoking. And you see these elderly guys in their 90s still smoking, but their diets are incredibly rich in extra virgin olive oil. And the extra virgin olive oil has to be fresh. And it's not what we get, on our shelves in Whole Foods or our local grocery stores. It has to come and be less than a year old. Ideally, months after it was harvested and cold pressed and, bottled, it has to be on your shelf and you have to consume it. And the way you consume it is with your meals. I think Kim recommended a tablespoon twice a day. I like to recommend a tablespoon before each meal. And you have to have something you eat with it because you need a vehicle to absorb the olive oil. The people along the Mediterranean consume 7 to 10 grams of extra virgin olive oil daily. And they did that ever since they can put something in their mouths. So if we get into those habits, we are going to help ourselves. Extra virgin olive oil has great benefits. And I think in addition to all the great medication approved by our FDA in this country, we can add extra virgin olive oil and cinnamon to help mitigate some of these risk factors.
So quick question is, somebody, for you doctors, how aggravating can it be to watch us, to know that we drive away from you? The first thing we do before we hit the red light down the road is smoke, or we stop at Whataburger or Dairy Queen, or we stop at 7-Eleven and get those big 7-Eleven drinks. And
I'm sure Dr. Schutz has seen this before, but I never forget a patient of mine during residency. We had a big aortobiphem, very calcified vessels, a very tall guy. We fix him. He goes home in 3 days. He's walking out in the parking lot and he's pulling his cigarette out and smoking. And we're like, I'm looking at that patient and I'm like, Jesus, I was in there for, 2 hours sweating bullets, I think almost 3 hours trying to get this guy fixed. And what he does when he leaves, he goes and he picks up a cigarette again.
Yeah. Well, that's a great question. Yeah, it's a great question, Doug. And there is a small movement to recommend that people that smoke shouldn't have anything done. I don't think that's right. We all have our flaws. We're human, right? And so I don't judge. I'm just here to help, and I can only advise. But it does bother me that there is a movement among some providers to deny care for patients that don't seem to be, all in with working with you on what needs to be done.
That leads us into a great question from Sunshine.
Hello. First of all, I just want to say I had to turn away from the phone for a minute because when you guys were talking about the bypasses, it just I had some feelings about it. Because I was a person that had a bypass and was told that it was failed and there was nothing else that they could do. And I'm learning from several different people that that's not true. Then you guys just reiterated that again today. So my question is, I now am a right above knee amputee. And because I've had to wait so long for a prosthetic and I'm still having issues with that, I haven't been able to walk, and the disease in my left leg has gotten pretty intense. I have less than 18% blood flow to my toes, but all of the disease is below the knee. And from what I've been told, below the knee arteries don't stay open more than a couple of months once they're blocked. Like they can go in and open it to heal a wound, but they are going to re-block again no matter what within a few months. And I was just wondering what your thoughts were on that. Is that something that you see a lot of, or is that just different for each patient, or is it pretty much across the board?
If I can elaborate on that, I do a lot of tibial work, and I do it for rest pain and tissue loss. And the patients that we open up, as long as your outflow to the foot is intact, those atherectomies and angioplasties may last you longer than just 3 months. And that's why it's important. My surveillance, for example, is after I do my intervention, the patients usually come in about 2 weeks because of our ultrasound availability, and they get their new baseline ultrasound. And then we monitor them, looking at those small vessels to see any velocity shifts, and also look at the outflow. And we monitor them 1 month, 3 months. And if in 3 months everything is healed up and the vascular flow is good, we see them in 6 months. A lot of my tibial disease, I don't intervene, more than maybe once a year. So they last longer, and we monitor those vessels that we've opened up. When I'm down there in the tibial vessels, I don't just focus on getting one of my tibials open. I make sure that I can maximize the amount of tibial vessels to the foot, as long as the foot outflow is there and it's intact, which means the arch of the foot, the vessels along the dorsalis pedis connecting to the posterior tibial, those are open and the foot is getting perfused. Also, at the same time, we're monitoring blood sugars and blood pressure and cholesterol, to make sure that they're optimized. So these results can last much longer. Dr. Sheets.
I agree. The treatment of below the knee disease, we call it BTK, has really advanced in the last 10 years. We used to be limited to very short balloons. We didn't have a lot of choices in diameters. There was really no bailout stenting, and there was nothing known as lithotripsy at this time. But now we have very small balloons that can track through really hostile vessels over small wires. We have great supporting catheters that help us get those balloons through these blockages that are quite hostile. We have very long balloons, that are 15, 20 millimeters long, rather than trying to use a 2 or 4 millimeter balloon all the way down. We can avoid dissection better. And then the newest development is something called lithotripsy, because people with this BTK disease have a high calcium burden in their arteries. They're more challenging to treat than the arteries higher up. But we now have lithotripsy, which comes through a balloon mounted system that comes in, and it can create these micro fissures in the calcium and help that artery to expand when we dilate it. So, but
absolutely,
in my opinion, this is a very high skill set. This is NFL major league level. And you need to have the right person taking care of you. Somebody that does a lot of these procedures on these vessels. So you're probably going to have to look for that person and find somebody that does a lot of this and understands all the nuances of the disease. As Dr. Anazano mentioned about that pedal arch, and then preserving that pedal arch, not losing it. So,
is there a correlation? Because we have quite a few in the group right now that are of amputees that have the same issues that Sunshine does with the opposite leg. Is there like a correlation between that?
Oh, totally. I mean, we have two of everything, and usually it's mirror image, of the other side. So yes, maybe one side will advance quicker than the other side, and but that's why surveillance is very important to preserve what that patient has. You mentioned, Shorty mentioned something that lifted a red flag for me. We have to understand that patients that have peripheral artery disease may also have something called chronic venous insufficiency. And we see that very frequently. 50% of our population suffer of that. And when you increase arterial blood flow into a lower extremity, usually you'll get some swelling, which subsides within a few weeks. But if you're persisting with the swelling of the lower extremity, you should be looked at to see if you have chronic venous insufficiency. Although leg swelling can also be an indication that your right side of your heart is backing up and you're having a little bit of right-sided heart failure. And so you're retaining more fluid in your venous system. But that needs to be looked at. And that's why it's very important when we manage our patients that it has a multidisciplinary approach to it. You've got cardiology, internal medicine, podiatry, et cetera, working. And a physician, a clinician, or a vascular surgeon who has the understanding of the whole entity of vascular disease, not just arterial disease, but also understands venous disease.
I think that's really important as well. And I'd love to with Shorty, if you guys can explain just the mechanism of action by which, I mean, that PAD can lead, especially if you have critical ischemia, to chronic venous insufficiency.
So we have what's called leaking valves in the veins, and 50% of the population suffer of leaking valves, regardless if they have PAD or not. So if you have chronic swelling of your lower extremities after your PAD has been addressed, then you should be looking to see if you have that condition. And if that condition is there, that could cause you to have congestion, venous congestion of the extremity. And you can develop ulcerations now, not because you have a lack of good inflow from arterial blood flow, but because the venous blood flow has been stagnated. And what is venous flow but, the waste blood that's, being collected from all the vascular beds, and it's brought back up to your heart, to your lungs, to get purified and recirculated back to become an arterial blood flow to your legs. So if that is backing up, that's also going to cause pain, discomfort, heaviness, swelling. And now, instead of having arterial claudication, you're going to have venous claudication and the consequences of that. What do you think, Dr. Schultz?
Yeah, venous insufficiency is very common. I mean, my office is filled every clinic day with many, many patients that have venous insufficiency. And I think the most common symptom is swelling. And then if you have chronic limb-threatening ischemia where the blood flow has been reduced, it may not have been, you may not have had those signs because you weren't getting much blood flow in. But then when you open up the blood flow, yes, then the swelling gets there. And it's supposed to be temporary. But if it persists, then you should be looked at for venous insufficiency by your vascular doctor and see. And there's different recommendations for that. Many times we just start with some mild support stockings, but then there's walking is also very good for treating that too, as it turns out. So.
Absolutely.
Is that just for the leg, or does the foot swell too? Because my toes will swell.
It usually starts in the toes and foot and works its way up.
Correct. And there's another entity called lymphedema, and lymphedema is more of a chronic condition. So that has to be distinguished between chronic venous insufficiency and lymphedema. That's why it's important that your clinician, is well-rounded, and when he sees you, he's not like a horse with side blinders. He's seen the whole picture. You as a patient, not with just pipes and sewage, but also, how is your general medical condition? And a combination of controlling all these things are going to give you the longevity and the success that you deserve.
Well, I'm Shorty, and I'd just like to say to each and every one of us that we must keep on fighting as a family to get answers. And if any of you know, does age really plays a factor in PAD in any of your life? I know it slows you down. It definitely slowed me down. And part of it, for me, is stress. Stress has a mean way of harming you with PAD. Bad enough having your leg and stuff on your mind the day that you just have to pick up and keep going.
Shorty, I'm gonna share that with you, and I understand right where you're coming from.
Yes.
I used to worry, live my disease. And I finally had to stop because I was going to end up killing myself just with my thoughts, depression, all that.
Yes.
And I feel better now letting it go and just living my life to the fullest and fight, like you're saying. But you can't let it get you down anymore. You have to reach a point of acceptance. And this is what it is, but I'm still going to lead a happy, full life to the best ability I can. And
yes,
yeah, I thoroughly get it, buddy. We've talked on the phone before, and I thoroughly get it, but you have to really let that go.
Shorty, I think once you get your prosthesis and you get moving around again, you're going to feel a lot better.
Oh yeah.
Yeah, that definitely would help, because seeing others move, it makes you feel like, when is my day coming? And I know my day is coming.
But we have to be aware, we all have to be aware, the number one thing of solving any problem is recognizing the problem to begin with. And I
And
think
most of the problems that we come across are ourselves.
yes. So, but we have to be able to
Unfortunately.
recognize that, because then you have something solid to work with.
That's right.
And that's what you and I talk about all the time, Alan, is that being able to recognize this is where I'm at. Now I can move on from here.
Yes, sir.
But if you're as 39 years clean and sober, if I don't recognize the problem to begin with, I don't know what I'm working with. And then I'm just stuck in the dark trying to figure it out. And it doesn't work that way. I have to be able to recognize from the beginning, there is a problem, so that I have something to work with. And
You
that's-
have to move into a positive direction once you recognize it.
And guys,
you know-
don't forget your faith, right? Faith is very important. And don't
That's
forget
all
that
part of
there's a prayer called the Serenity Prayer, you know?
Yes, sir.
You know, you have to accept what you can't change, and you have to have courage to change what you can. So, you know, just remember, you know, a lot of these spiritual teachings that were left to us are very, very important, and they will help us get through, you know, these dark times, so we can find the light.
All this goes back to that part where we have to take responsibility for our part when we drive away from your office. When we're sitting at home, eating properly, making sure we walk, stopping smoking, drink the water that we're supposed to drink, and all the things that we're supposed to do as patients to assist in being better patients with our PAD.
Correct. It's developing new habits, breaking the bad habits, and bringing on new habits to help your general state.
We also had a question from Michelle about her lipids. She had posted, what if your lipid profile is normal and your LDL below 70 and you still progress?
Then you have to think that there's another problem, right? Dr. Schutz?
Yeah, that's a great question. And that gets down into the other components of the lipid profile, right? The VLD or your VLDL be high, or you start having problems with other types of the lipid world, where we start looking into lipoproteins. There's apolipoprotein alpha, beta, and the lipoproteins can be working against you. And that's where I go. I just, rather than try to learn this myself, I just send it somebody to a lipid specialist, because I've tried to learn about it. It's too complicated for me to figure out. So I'm very glad that there's people out there that are super smart and they get it. But that doesn't mean that there's nothing else that can be done. Definitely keep fighting and get in the hands of somebody that's very skilled with lipids, and they'll order another lipid panel that includes all of these highly specific lipoproteins that we know play a role in the whole disease process, but they're not the main driver for most of us, and that's why it's not part of the regular panel. It's for that subset of people that aren't responding.
Absolutely. And thank God it's not very many of them. But I think overall, the most important thing you have to look at when you're looking at your lipid panel is your high density lipids. You want those HDLs to be above 50, as high up as you can get them up, you know. And there are ways of getting them up with your diets, or diet and exercise. Olive oil, absolutely. You know, I listen to people about the Mediterranean diet, and it just amazes me to see some of these Europeans, and I'm sure a lot of us have traveled to Europe, and you're walking, you know, in a little Mediterranean town, and you see these old folks smoking their cigarettes, you know, and you're like, Jesus, you know, they're walking fine. They're carrying their little pail of milk from the dairy farm, or they're carrying their pail of olive oil, but they're smoking, you know, and they might not be in the greatest health, but they're walking, and you wonder, wow, you know, so they smoke and they're eating a lot of olives and olive oil. That must be something positive. It's remarkable. But there's something I said that you have to take with a grain of salt, and that's that these 90-year-olds or maybe 80-year-olds are smoking and eating and consuming olives and olive oil. That doesn't mean that you can consume olive oils and continue smoking. Okay. And you probably would live to be over 100 years old, like some of those people in the Mediterranean, if you don't smoke. Smoking is so detrimental to us because it creates that inflammatory response in your endothelium. And I tell my patients, it's like if you walked barefooted on cobblestone, what's going to happen to the soles of your feet? They're going to get thick and hard. The insides of your vessels, when they get attacked by the nicotine that's circulating through your bloodstream, creates this edema, this swelling of those intimal cells in there that are covering, your arteries, and they die. And what happens is that they die, and new cells are brought on top, and you have all this cascade of inflammation, and you get cholesterol deposits and thickening of the arteries, and then you get, PAD. So get away from it. Cigarettes are not good for you.
Well, the ex-smoker in me thinks you said that, because the ex-smoker in me, when you said it a minute ago, was already thinking, hey, wait a minute now. Maybe I can start the Mediterranean diet and go back to smoking. That's the ex-smoker in me.
No. Yeah, absolutely. No, get into eating, healthy and enjoying the olive oil and the olives. That's God's greatest gift.
It's interesting that the having a healthy lifestyle, actually, you feel good. It's a secret that nobody. It's almost like when we try to sell this to people, that we're taking away the things that make them feel good. But no, you actually feel better when you live a healthy lifestyle.
Doctor, I can attest to that. For years, I just felt like a slug, and then I got diagnosed with PAD and changed my life. I have never felt better, even though I have PAD.
Great.
It's incredible.
Yeah, I can say the same. I can say the same thing. Yeah, diet and exercise.
No, not today.
Getting rid of the evil stuff gets rid of the pain, guys. And eating good stuff doesn't mean you can keep doing evil stuff. You got to stop. You're just causing pain to yourself.
Mm-hmm.
That's
totally.
Don't forget portion control too. Portion control. Our portions are out of control. Don't forget. Especially when you go out to eat. That's about it. But you guys are right.
But now,
how do you feel about alternative care like acupuncture or anything like that for people that have neuropathy?
There's all types of alternative treatments. Acupuncture is just one that you've mentioned. There's essential oils. There's massage therapy. All types of. There's even over-the-counter type of supplements that have been mentioned, as well as others. So I have a pretty open mind. I don't use alternative medicine as main treatments, but when I have somebody that's interested in using that as an adjunct to what I've already recommended, I'm totally endorse the idea, because I have people come back and witness to me that they've tried this or that and it's helped them. And I can't say that, no, it didn't help you. I helped you. No, they believe it helped them. And so I'm a totally open mind about it. Now, I don't necessarily recommend alternative treatments because I think it's very individual. And I think alternative medicine does help some people, but I don't think it helps enough people to be recommending it to everybody. I think it's just individual. And so I totally endorse and support my patients that want to try alternative medicine as an adjunct, not as a replacement to what I would consider standard therapy.
We see all the time more and more chiropractor offices. And I know you've seen the ads in the newspaper and on TV. Got neuropathy? We have the solution. And I always cringe because a lot of them are money-making ploys, and you have the red lights, green lights, blue lights, yellow lights, all the lights in the world. And then the pads that you can stand on that increase circulation. You have people that are telling Deion Sanders, whoa, just get a massage and just massage the circulation down. And there's so many things that I'm like, no, hold on. If your neuropathy is directly caused by a lack of blood flow, that stuff can actually cause more harm than good. And I think that's really important to note, right, doctors?
Absolutely, absolutely, and it can be a
Totally agree.
challenge sometimes discriminating when somebody's having symptoms. What are neuropathy symptoms and what are vascular symptoms? It can be very difficult to discern that. And I've had some folks that had pain that we've treated their PAD to improve their blood flow, and their symptoms persisted. So I try to have an honest conversation and say, listen, I really can't tell which it is. The only thing I have to offer is to try to get you some more blood flow, and then we'll see.
Yeah.
Yeah.
And what I find is that with some of our patients, because they actually walked themselves into CLI and permanent neuropathy. In some of the other countries here, I don't see it as much, but we do have it in some of the other countries where they literally say, well, walk until you need an amputation, and then we'll do that. And they just end up with permanent painful neuropathy that even if you did restore blood flow at that point, it's not going to bring them enough relief. And so they're just like, you know what, cut it off anyway.
Yeah, the painful type of neuropathy is another horrific condition.
And there are specialists that manage it. And now we're kind of evolving in that sense with stimulators and stuff to help these patients with phantom pain. Unfortunately, in some of our patients, the end result's going to be an amputation, but thank God that we do have great, orthotics and prosthetics out there that'll help our patients, and also these devices to help with the phantom pain and the chronic pains that they may have. Amputation is, it sounds like, just cut off the leg and you're done. But there is a technique, there's a way to do the amputation. And, if you ligate those nerves appropriately with the right type of suture, you can avoid having these chronic neuropathic pains in your patients. Do you agree, Dr. Schutz?
Oh, absolutely. Absolutely. There's different skill sets and different levels of commitment to providing, not only an operation for the patient that needs an amputation, but also the preoperative and postoperative care, and then the chronic ongoing care. And that's actually an area that there's not uniformity in this country. And the SVS is, I proposed to the SVS executive board last month, and I hope it gets some traction with a concept to create a working group to look at, comprehensive pre and post amputation care for a patient that covers the whole 360 degrees, related not only just to the operation, but nutrition, ambulation, psychosocial support, social determinants of health, prosthetics, and several other areas, pain control, and then phantom pain minimization, other areas. So I'm hoping the society will back this concept, and we'll get a working group going to come out with a comprehensive document laying the groundwork and the landscape for everybody in that space to start doing comprehensive amputation care in the same fashion, which isn't being done now.
And I think that I'm sure Sunshine and Alan and Shorty would love to be on that, part of that, because of their experiences with it. It's disconcerting still that, as Deion Sanders was in that first video, was seemingly encouraged to go the amputation route. He's the exception to the rule in terms of proper care, because more than 60% of amputees that have PAD, they don't even get prosthetics in a timely fashion. And Sunshine's sitting here, 2 years in? We have one in Canada that is like almost going on 3 years in without a proper fitting prosthetic.
I just got the new one. It broke the day after. I have to try to have it repaired. So hopefully they'll be able to repair it, because the socket that they gave me this time is an adjustable socket. So it has like these little strings, and then you use these dials to kind of tighten up the socket. Well, the string broke when I was trying to put it on the day before yesterday. The string broke. So he said because it actually has like a magnet that I lock into. So when I called my prosthesis, he got me in Monday, he said that I can actually still wear it because I'll be locked in with the magnet, but I just have to use my walker. Like I can't use the cane or the walking sticks or anything like that. I have to have the walker because obviously that's going to be the safest way.
Well, we'd love to have your participation in our working group if it moves forward. The whole concept of this group is it's going to be, multifaceted, not just with the surgeons, but everybody from those domains that I mentioned, including patients.
My biggest concern about, considering that I went through 3 amputations in 2 months' time, and my biggest issue was wound care. After, the amputations, the wound care, that's something that has to be, it really just needs to be a #1 priority for amputees because of my poor wound care, or just the poor care that I had throughout the whole ordeal. It didn't stop with a toe amputation and a bypass. If I was looked after properly from that, after the bypass, I may have not have needed a below the knee amputation. And the same thing with the below the knee amputation. If I was looked after, if my wound care was up to par like it should have been, I wouldn't have ended up an AKA. And that's and that a lot of people, I express this to a lot of people and they think that I'm just being like, one of those patients where, oh, this shouldn't have happened to me, as a lot of patients are. But the cold hard truth is this should not have happened to me. I should have been okay with a bypass and a toe amputation. It should have never went any further than that, but it did because of the lack of care and wound care that I had.
I actually see that a lot. Alan just dealt with that. And I also just had a patient with a revasc in Florida doing great, but then the wound care professional ended up wrapping up the wound so tight and told the patient not, keep it wrapped until next week, ended up with Pseudomonas. Pseudomonas thrives in dark, damp areas. So while this revasc happened, they were going to say, Blake, he may end up losing it because of improper wound care. And Alan, you just got through with a second amputation because of that same issue. You have to unmute.
Alan, you're muted.
Okay. I had open wound surgery because I was so swollen, and there wasn't one vascular surgeon didn't leave enough material after fasciotomy to do a full closure. So I have been fighting this for, 4 months now, 5 months. And finally, I got osteomyelitis in the fibia. They had to take another inch off. This was 10 days ago. But back, with the wound care, we don't know how I got it. We were very, very diligent with the open wound. But I'm down resting. I put it up and I just let it air itself out. And hopefully this is the last one that I'll have to go through. I don't want to go through anymore because then I'll be an AKA also. But I feel so for you, Sunshine. I know that was my biggest worry is that happening.
One of the things that irritated me and that I keep going back to after my AKA or my BKA, I'm sorry. They sent me home. I went through the rehab and everything in the hospital. They sent me home. They said everything looks fine. But for me, before I even left the hospital, I knew that something was wrong. I had a black scab, which I associate with necrosis. And they kept saying, oh no, it's just dried blood, this and that and the other.
Yes.
And then, every week when I would go into wound care, it would be something else. I would be like, this isn't right. My wound is now splitting open, after they took took the staples out and the wound started splitting open, and they're like, no, this is normal. And it wasn't normal. And one thing that irritated me is that the doctors refused to listen to me. They refused to take my concerns into consideration until it was like, oh no, something's wrong, all of a sudden. And then so they have this wound care doctor come in and do a partial debridement, and then he left me like that for a whole nother week. And when I came back the very next week, it was like, oh no, you have to have a surgical debridement. And then when the surgeon came in, he said, no, we have to cut that off because your bone is now infected.
Oh.
And if these doctors would have just listened, because I'm the patient, I know my body better than any doctor in the whole entire world. I know when something's wrong. And if you have a lot of doctors that think we're all stupid.
And we're not.
That we don't know our bodies. That they, just because you're walking around with, a degree from wherever that says that you're a doctor, that you know more than I do about my own body. And you don't listen, and people that don't listen to their patients.
That's where the advocation comes in.
To your patients.
That's where the advocation comes in. If you don't advocate for yourself, nobody else is. And that's where I took myself out of the element I was in, got out of it, and went somewhere else.
Eventually I had to too. But, when I was stuck down there in Mississippi by myself, alone, with nobody there to help me, so I didn't have any choice but to keep going back to the same place because nobody else would touch me. I tried to go to another hospital to get help, and they told me
they kept sending her back to the original. Yeah,
they sent me back to the original because the original surgeon, nobody else is they told me this person did the surgery. Nobody else is going to touch you because this person did the surgery. So you have to let them take care of you now. And they sent me back to the same hospital.
That's sad. That's so sad.
Doctor, I'm wondering what do you think as a doctor about what kind of solution is there when you do everything you can for a patient and then these kinds of things happen? When you're actually trying to save the limb and then they go on to get bad wound care and things.
Yeah, that's something we struggle with.
Absolutely. And it is. And it's Dr. Schutz, what do you think about, these patients with these wounds? And what about the surveillance? Is there blood flow adequate? Has their blood flow decreased? Is there a necessity to go back and do an angio on this amputated leg to make sure that the inflow is fine?
Yeah, it's
TCOMs, getting TCOMs on these patients to see what the oxygen tension is on the skin, if they're going to heal or not.
Right. There's a new device that's just come out that was at the Vascular annual meeting last week that will actually can do continuous skin oximetry monitoring. So I'm hoping as this device becomes more widespread, we might be able to get that for our post-operative patients who are going to a facility where we're not really involved in their care and sometimes excluded from their care, and we're not informed about what's going on. But at least if they could have this out there, it might be a little bit of an early warning. There is one thing that one practice change that we've made in the last few months that's really been a game changer in monitoring our patients who have a revascular procedure, have a wound, and end up in a facility or under wound care. And we have them take a picture of their wound whenever the dressing is changed from multiple views, usually about 2 or 3 views, and we have them email that to the office. And then it gets put in my inbox. And so I'm able to scroll through and watch the status of the wounds. And, another story, it was about 2 or 3 months ago, I had one of my high-risk patients who lives about 2.5 hours from here. And he actually had good wound care, but he was sending me pictures and I could see that something was going on with his foot wound. And I said, I want you to come in this week, next available visit. Let's get you down here. Let's see. And sure enough, we got him in, and he had developed another stenosis in his stent. And the foot was just about to get infected. So we got him on some antibiotics, got him in, did an angioplasty on the narrowing, and got his foot going back in the same direction. So the main issue is, when patients leave our care, leave our facility, whether they go home or more often to wound care or another facility, we're not getting those regular updates, like when you're in the hospital, we see every day. So that's something that we've changed, and then hopefully other people will start doing the same thing, because the technology has moved to the point where, with your phone, you can take a picture of the wound, you can email it, the doctor can look at it. It takes the doctor 10 seconds to look at the wound and know whether it's okay or not.
So the importance
I
of
agree.
wound care is really that important after an amputation, isn't it?
Doug, did you say that again?
The importance of wound care after an amputation is probably one of the most important.
Right. Two things: wound care, but I think also surveillance, letting your vascular doctor see those wounds regularly, so they can see what's going on. That we're not just waiting when somebody says, "Oh, I guess you better get back to see your doctor," and by then it's too late. So
we do the same thing out of our institution. We have the patients actually send us pictures directly to our cell phones. So I get pictures periodically and I survey them until they're healed up. I don't keep my eyes off of them. I know that if they have stagnation of wound healing, that they're going to need another ultrasound and possibly another angiogram to increase more blood flow to the extremity. So surveillance, pictures, using the technology that we have at our disposal is very, very important to managing these patients.
Is there a custom set of rules for like wound care, or is it just, does everybody do it different?
Unfortunately, there are no global standards for wound care in general, or for post-amputation stump care. Again, that's what I'm hoping our society can address, and will fill in that gap. I'll know in the next few weeks if this project is approved and will be funded and can start moving forward. The timeline will probably be at least 12 months to get to the finish line with it. So we're looking at something maybe by next year. But yes, that will be some part of it, will be that post-procedure care to maximize the ability for wound healing, shooting for 100% and not settling for 70% rates of successful, uncomplicated healing.
But shouldn't it be?
Dr. Schutz, make sure you include me in that. I would love to help you.
Oh, wonderful. Glad to know. That'd be great. We'll sign you up.
Shouldn't wound care be personalized patient to patient though? Shouldn't it be?
Well, when you say personalized, it should be personalized to the etiology of the wound, right? There's venous wounds, there's arterial wounds, there's pressure wounds, there's infected wounds, there's uninfected wounds, right? There's wounds in diabetics, there's wounds in non-diabetics, right? There's wounds from calciphylaxis. And then there's other issues related to the patient, right? There's transportation issues, right? There's accessibility issues. So yes, so there should be some personalization, but there also needs to be some minimum standards for what we're talking about is post-amputation wound care in regards to frequency, best practices, right? When to use negative pressure dressings, right? As Kim mentioned, not wrapping a wound for days and leaving it alone. Not just leaving it there and let it develop what is the perfect culture medium for Pseudomonas to grow.
I'd love to be a part of it too. And if I can help in any way, write a letter to help expedite or help, add fuel to that, happy to help.
Well, great.
With
that's great to know. I didn't anticipate that this would come out of my participation today, but I'm very thrilled. Very, very thrilled. The working group that I put together is 5 people from around the country, from the Northeast, from California, from here in Texas, from Alabama, and everybody's real passionate about creating this safety net for amputees, which doesn't exist.
It'd be great if we could also just include just in general, and even with bypass, we had someone that had improper care of the incision, and that just because of the infection in the incision that just kept going deeper, almost ended up with an amputation. If we didn't have a cardiothoracic surgeon who just had a special interest, he's one of those anomalies, just a real special interest in wound care,
and was able to go above and beyond because he's a part of a couple of studies on some advanced methods. He was able to save the leg. But we also find it with bypass incisions as well that we have the issue.
That's why the technique is very, very important. The manipulation, very old school. You know, when I do open surgery, the manipulation of the tissues has to be in a manner the vascular bed, the superficial vascular beds. I'm a proponent of, for example, a harmonic scalpel, which instead of using electric cautery that has a big radius of damage to the tissues, it's very localized. And so it's very good for, you know, a prompt healing of your suture.
Tissue management is essential in minimizing the injury to the tissues during these procedures to maximize the opportunity for wound healing. It's overlooked many times, but it is one of the critical components of performing these procedures. Is the tissue management, and I had not considered the idea of using a harmonic scalpel, but I'm going to look into that now because I've always tried to use the lowest electric cautery settings to minimize that zone of injury, realizing that we don't see it, but it's there. You know, and you put the tissue back together, and then it doesn't heal, and that's because of the trauma that was created by all the energy that was delivered. But the harmonic scalpel sounds like a beautiful solution to that.
When you started out in this field, at what point, I've always asked every doctor who come on this same question, at what guided you? Was there a specific time or specific moment that got you into this, where this is what I want to do?
Yeah, well, actually there was a moment. I was in my first year of residency at the University of Alabama at Birmingham, and I was in my 6 months, at which time I was deployed to the VA at Birmingham on the vascular surgery service, and I hadn't really had any exposure to vascular surgery. I was, signed up to be a general surgeon, and vascular surgery at that point was just beginning to become its own specialty. And so the first week, I was able to, admit a patient that had a blockage in the superficial femoral artery in his leg. It was a total blockage. There were no endovascular techniques at that time. There was no angioplasty. It was that long ago. There was only surgery. So I couldn't feel any pulses in his foot. His foot was cold. He went to the operating room the next day, and I assisted while the team did a femoral popliteal bypass. Procedure went well, and then the next day I grounded on him again in the morning, and foot was hot. I mean, it was bright red, hot. I could feel pulses easily. I was amazed, and that was what first hooked me into vascular surgery.
Excellent. I mean, and it's changed so much, hasn't it?
Well, I'm very fortunate. God works in strange ways, but he has a journey for all of us. And that moment put me on a path to where I've had a wonderful 30-year career in vascular surgery. I've been part of the rapidly evolving field that continues to advance in an exponential way in treating this disease from multiple angles, not just the medical therapy, but the interventional and surgical therapy. I've been very lucky and I didn't realize this at the time, but vascular patients are the best patients in the world. I developed longitudinal relationships with all my vascular patients. I get to know them. I know their families. They know me. They know my family. We're always talking about our kids, grandkids, etc. So it's been such, as a surgeon, it's been wonderful to be in a field where I've had such long-standing personal relationships, which is different from other surgical specialties. You break your arm, you get it fixed, you don't see the surgeon again ever, right? You have your gallbladder out. They take your gallbladder out. You never see them again. I get to see my patients over and over and over again. I get to see their kids. Sometimes their kids become my patients. So it's just been a wonderful career. It was a true blessing to have that rotation at the VA in Birmingham and have that one patient come through that kind of changed my trajectory.
Well, early on in my education, I had the privilege of working with an uncle who was a general surgeon who
was also a grandfathered and vascular surgeon in Florida in Palm Harbor. And he did incredible vascular work. And for me, that was when I fell in love with that specialty. I went and did general surgery first, 5 years, and then I did a 2-year fellowship at the University of Missouri. But my love started there. And that's where I saw the need for that skill set to create perfect bypasses. He used to do these incredible bypasses, and sometimes he would do bypasses to the perineal artery, which is the tiny artery between the two bones in the distal leg. And I would see how those would work and how we would monitor them, and I was amazed on how, you know, his skills were so incredible, and I wanted to emulate him. I wanted to be just like him. So that's when I went into the vascular field. And just like Dr. Schutz, you know, I don't have just patients, but I have family members. You know, my patients, you know, they just become family members, and we see them for a long time until, sadly, some of them get to the age of, you know, passing away. But many of them, you know, are still around, you know, coming to the clinic and seeing us. And we develop these relationships and this rapport that's very unique for vascular patients. And I think you've heard me say before, you know, I tell my patients, when you come to me, you've inherited me. You know, it's either you keep me until you fire me, or I die, or you die. You know, we have this bond for the rest of life.
This is that disease where we are connected, isn't it?
It is, absolutely. You know, and it's our responsibility as your providers to be up to snuff and speed with the evolving technology that surrounds us and evolves. You cannot stay, you know, 20 years behind and keep offering the same technique to your patients. You really have to pick up the newest technology, the newest and latest technology, to be fair to your patients. And if you get to a point where you don't want to, it's time to hang the hat and go and relax and get on the beach somewhere and drink some pina coladas.